Siobhan, you said you were really excited because you'd been using clean language in a visit recently and you came out of the house and you were so excited. So I haven't really heard much about it, so I'd love to hear about what you've been doing.
Okay. The reason I was really excited, just to set, I mean, I am excited about clean, but I'm an absolute novice. And I was excited because clean popped out of my mouth without me thinking about it. So that was quite exciting because normally I plan or consciously add it because I'm still practicing. So I'll tell you what happened. I'm a palliative care nurse, so it's a bit nursey. In my job, sometimes other specialist nurses phone me to go and ask me to see their patients for some specialist palliative care reason. And a community matron asked me to go and see a patient who is 85. She's got an anal cancer and there's no treatment options. And she's a frail lady, and she had a head injury 15 years ago. And so she had some cognitive impairment, but she had been living on her own, had a family, had a job with her head injury. So there was a change in her cognition. So she had like a disease bulk pain and a nerve pain. So I'm so nervous presenting this. So I went to do a visit and I was a guest in the visit because it's not my patient. And so initially I just observed and got a feel for Alice. So I believe that when I'm working with patients with pain, not in the same language as obviously clean and models like that, but I have to learn their language of how they describe their pain, or I have to teach them a language, or we find a language together, because otherwise we're not going to be able to do anything. But in watching Alice, she didn't really have any verbalization for her pain. She was in pain or she wasn't. It was as simple as that. And she just was in pain, but she had no adjectives for it. But she had a lot of non-verbals. So I knew from the matron that she was a very calm lady, and she has the most engaging smile. She's just a really warm person. But she was distracted, she was agitated. We only spent 45 minutes with her, and she was rocking back to forward, and she kept going up and down, up and down, up and down to go to the loo. And she was leaning on her elbows, so she was lifting herself off her bottom. So I won't bore you with the pain assessment bit, but I felt that she had some tenesmus, which is like a pain in your anal cavity, which makes you feel like you need to go to the loo all the time. So I'm not sure that's a brilliant description, Saskia, but you know what I mean. So I started her on some nifedipine and titrated that. So that was that bit done. But what I observed is that Alice had no language for pain. And also, I suspected she had dementia. Irrespective of a head injury, I suspected she had dementia. And so I've always found and believed that when someone's got dementia, you kind of have to access through a different route. And sometimes that's not verbal, even though she had verbalization. And I've always found that the visual sometimes works better when I work with patients with dementia with pain or symptoms. So I worked with the home a little bit with their pain relief, as well as the nifedipine, which is going to take a while to kick in. I added some oromorphin. And I asked them to be very specific about it and tell Alice that it was a pain relief, and be very specific with their words. Not that this is your medicine, but this is your pain relief. So she could see it. That makes sense. Sorry, I'm waffling because I'm nervous. And then I also, so that's all the changes I did. I titrated the nifedipine over a period of time, and then I got another phone call, not by seeing her, through the community matron. And then I got a phone call from the community matron to say she wasn't sure where to go with the pain, and she was going on holiday, and the nursing home needed some help. So that's fabulous because I got to go and visit. So I went out and did a visit. So I pulled up outside the nursing home and was sitting in the window at a dining room table on a wooden chair, a wooden dining room chair, and she had her bottom flat to the chair. So there's no way I'd ever seen her sit like that before. When I went in, she had had her lunch, and she was full of smiles, and she told me about her lunch. So she'd obviously sat on that chair for the duration of lunch. I helped her get up to come and speak to me in a different room, and she pulled a face when she got up as though she was in pain. And I said to her, have you got pain? And she said, yes, in my knees. And if you're a palliative care nurse, sometimes you get very excited if someone's got a new old pain when you've been dealing with an acute pain, because it tends to mean that the acute pain is better. So I thought, oh, that's quite cool. Obviously not about her knees. And then I asked her if she wanted to go to the loo while we were walking to the other room. And she said, oh, no, thank you. I don't need to go. Now, bearing in mind, at the last visit, all she wanted to do was go to the loo. She couldn't even concentrate. So we went to the lounge. And I thought, I'm not going to do anything with an ephedrine because I'm only going to have a little bit of conversation with her because she couldn't cognitively do a lot. So my non-verbals were, I was on the right track with that, I felt. So then I said to her, because obviously I was in a uniform, so she thought I was nice, but she wouldn't have remembered who I was. So I said to her, and my language was simplistic, not to be disrespectful, but to keep it clean in a different way, not a Judy way, in a just not too complicated way. So I said, I've come to talk to you about your pain. And she pulled this face, like not a good face. And I sat down and I said to her, have you got pain? And she said, yes. And then I said to her, I've come to talk to you about your liquid painkiller, which is the words I'd asked the home to use. And her face was a smile. I thought, oh, that's cool. I'm not the world's greatest nurse, by the way. It's just a very simple piece of care, but she did smile. And so, and then she said, I like it. It works. And I was like, oh, maybe I am a good nurse. And then I said, is there anything else about your liquid painkiller? Honest to goodness, I didn't plan to say that. And then I said, it doesn't last long. Now, for Saskia and I, we would find that a very good piece of information because that tells us that that pain that was bothering her is opiate sensitive. And we wouldn't expect it to last because it's an immediate release medication. I honestly nearly peed my pants because I didn't expect to be clean. It popped out. I was so proud that it popped out without me planning it. But also, wasn't that like for Saskia and I? That is such a good answer. It's so good, like gave me so much information. And then I remember Judy, because I remember thinking when Judy said, oh, you can repeat it up to 6 times. I know I keep saying that, but it blew my mind when she said that. So I thought, well, I'll ask again. So I asked her exactly the same question again. And she said, I think I need a tablet. So now I know that what I did with that afterwards is not maybe clean, but I do believe, and I had a hunch that she needs to see her medicine. But she said, I think I need a tablet. Now, the medication that she was on beforehand is not a medication I love. It's an opiate patch. I don't like them. I find them clunky. It's so difficult to go up. And she's clearly going to need to go up because of what's wrong with her. So then I thought, I'll just ask one more question in a sort of dementia clean way rather than a clean language way. And I said, what about your pain patch? And Alice shrugged. And her non-verbals are very important because she's really expressive. And she said to me, nah, that only works on a Sunday. Now, it's a 7-day patch that is changed on a Sunday. So then obviously I did feel like Florence Nightingale because I thought, that's amazing. Like, so I'd like to think that I'd put the time, I would put the time in. I'm that kind of person. I would have done as many visits as necessary. And I would have found Alice's language and I would have found it. And I would have probably gone off the patch anyway, but literally wrote a palliative care plan with her clean language because she told me that opiate worked. She told me the immediate release didn't last. And she told me that she needed to see it, both by saying the tablet, I think, a little bit, because to her, a tablet is pain medicine. And the patch thing, it was just how I didn't, like, I must have been smiling as much as her really, because it was just perfect. So what I did, which is not very clean, but I needed to really evidence what I was thinking. So I did a straight conversion of the patch to a tablet. no increase. I left everything else the same. And her Oromorph, by the way, wasn't like PRN in the traditional sense. I'd gone through her activities of the day with the nursing home to find out when she was unsettled. And I'd put the Oromorph half an hour before then. So even though it was PRN, I'd been very prescriptive about it. Didn't change that. There was no increase in drugs. Then I went to the nursing home, back to the staff, and I taught them how to give her tablets, not disrespectfully, but like to make the language around it repetitive and very clear. This is your pain tablet. This is your pain meds liquid, you know, really clear. Anyway, I was a little bit, I was desperate to review her, to be honest. And she wasn't my patient. So I stalked the community matron, which luckily is one of my friends. And I said to her, oh, please go and see her. Just tell me what's going on. Because I can't like toddle off into other people's patches. Anyway, a couple of weeks later, Michelle went to see her and actually now verbalizes that she feels her pain is better because she has her tablets. And she still has the Oromorph, but sometimes she says, I don't need it, I've had my tablet. And I know all of that is not clean. Some of that is trying to work with someone with dementia. But honestly, Judy, when that question came out of my mouth unplanned, and then she said, it doesn't last, I just thought, wow, that would have taken me weeks to access. I think it would have taken me time. And it just all happened in one consultation. And she's not even my patient. It's not someone that I've had the luxury of building a therapeutic relationship with. It was a clean consultation on someone else's patient. And so then I got quite excited, to be honest. Because my practice with Maybe Clean, I appreciate I'm a novice, but it's becoming more fluid. It just happens a bit more. But also, I was quite excited that I could use it with a dementia patient. And that's what I wanted to, that's what I really was busting to phone Judy about when I came out of the nursing home. Because I was like, is that how it works? Like, can we use it more with dementia patients? You know, anyway, that's what happened.
This isn't a very clean response, but I think you've just demonstrated that you can, Siobhan, and it can be really helpful.
Yeah, I do appreciate, I get a bit excited about, I like my job, I like being a palliative care nurse, but like, that was amazing that we could access someone with like such complicated pain. Like, she has got 2 neuropathic pains. She's on an opiate pre-gab and nifedipine. And she's going to have more pain, and she doesn't have a means to tell us. She doesn't have the same fluidity. And like, she wrote her own plan. Honestly, yeah.
Amazing.
Yeah.
Amazing. Thank you so much, Siobhan, for sharing that with us all. It's just, and your enthusiasm is absolutely infectious. And I'm going to hand over to Jo for the
yeah, absolutely brilliant. Really, really brilliant. And, don't worry about being nervous at all, because it's just exactly, this is you speaking from your experience, from your heart, and it's fantastic. And just seeing the difference that it made for that individual is incredible, and that's what it's all about, isn't it?